I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to another episode of Women's Health Unplugged. I am excited to dive into this very menopause-focused conversation today, but I'm gonna venture a guess that this conversation is one that all women, all people with ovaries need to listen to, because this, we've talked about it on the podcast a lot, that sort of focus around midlife. And we really have an important guest on the show today to help us dive deep on some of these pieces around this conversation. We're going to talk about HRT. We're going to talk about myths. We're going to talk about preventative medicine. I'm joined today by Dr. Heather Hirsch, who is a medical doctor in the US. Heather, I love that you have coined the term, "I'm a cool doctor."
You know what? I won't take credit for that. That came from my web designer. So she told me that I was a cool doctor. So yeah, that's where it comes from.
Well, you definitely are living up to your name over the last
Thanks.
little while. And if Heather has not crossed your Instagram feed at this point, I am sure she will any moment between appearances on Oprah and some of the major podcasts out there. Thank you so much for spending time with us today, Heather.
I'm so excited. And actually, when I look at the three big cities where I have a lot of followers, Toronto is one, which is not if you're necessarily near Toronto, but my Canadian followers are actually quite strong. And then New York and Los Angeles, those other two big cities. So I'm so excited because I'm sure your show hits a wide population, but you are the first in Canada that I've gotten to talk to in a while.
Amazing. I would love if you could just give us, I'm going to call it the Coles Notes version of how you got from, that being that spark of interest in menopause to being center stage of the menopause conversation. I'd love if you could walk our listeners through your last couple of years and how you got here, because I think it speaks volumes to just how important you find this conversation, this sort of like relentless pursuit that you've been on.
It is a relentless pursuit. The quick and dirty is that it's really every single conversation that I have with a patient, with a woman, and I have so many during the week because I'm a clinician at heart. Every single time I feel this sense of joy that I get to take care of my patient and help her, but also like that anger that fuels you of like, it's so unfair. It's so unfair that women are left wondering or searching. There's this statistic that women see on average, like 4 to 7 doctors in perimenopause to menopause, trying to figure out what is wrong with them. And so it's literally every conversation that I have with a patient makes me more and more motivated to put myself on social media, which is not always easy. Yesterday was a rough day. And keep saying the message and keep putting out the content and keep the dialogue going, because my patients truly are what remind me of this. And very briefly, I was a women's studies major in college, so I always wanted to take care of women. I never thought I was going to be a menopause doctor. In fact, I wanted to actually deliver babies. I thought, well, that's how you take care of women. But I did a fellowship at Cleveland Clinic in 2014 and saw women come from all over the country to Cleveland, which we dubbed the mistake on the lake, to figure out what was wrong with them and be treated by my mentor, Dr. Thacker. And that was really my aha moment of, this is the area of women's health that is just a gaping black hole that no one has really been able to jump into feet first and really help people. There's so much confusion. There's so much myth. There's so much dismissiveness going on. We've got a lot of things in medicine, I won't want to say figured out, but pretty well outlined and protocolized, but not really midlife or actually anything women's health after childbearing, if we even choose to have kids.
It's so interesting that you say that because you're right. Like often when we are thinking about going to medical school or being in healthcare, when you think about women's health, you think about babies, right? You think about pregnancy. And even when I look at like my profession over the last few years and who the clinicians we support and what their focus is, it's always fertility, pregnancy, like that's women's health. And yet, like it's a moment in time, really, when we're thinking about that woman's like lifetime experience and the way that midlife it impacts them, anywhere, I'm going to say from maybe 35 onwards, women are starting to experience some changes that are impacting the way that they can show up day to day. It's so interesting that you had that because that you can articulate that because I even see that in what clinicians say they're interested in with respect to women's health.
Mm-hmm. And it's interesting what you say is that while pregnancy is sort of a snapshot, although, definitely a difficult one, but, in medical school, menopause is treated as a snapshot. Like it's this one thing. It's when your periods stop, when in actuality, that loss of estrogen that comes along with menopause is deeply interwoven into chronic diseases like diabetes, like weight gain or metabolic syndrome, like depression and anxiety. And so it's funny, like we almost need to flip flop a little bit how we think about women's health.
I love that. I love the way you put that. And actually, there's some great menopause groups that are trying to like change that narrative where they're like, okay, the word menopause means like one day, except the experience of menopause is lasting, a lifetime, right? For those women. And so so what did you see in those women that made you so interested in helping them? Like I just want to normalize that experience that our listeners have when they're seeking care and they don't get what they're looking for. Like, what did you see in those people that made you so passionate about supporting them?
Certainly I'm going to say for those women who can and who choose to use HRT for a second, I'm going to kind of go down that path. When I began to feel comfortable prescribing HRT and learning the safety, learning the efficacy, learning the FDA approved options, and patients would come back to see me, they would look like brand new people. It was like delivering a baby. It was like a woman giving birth to the best version of herself, right? It wasn't delivering a baby, but I was helping her in a way that really would change the trajectory of her life, her friend groups, her marriage, how productive she is at work, how well she sleeps, how long she lives. Like it was eye-opening. And to this day, it never gets old. I actually had a patient right before we jumped on this podcast and had started her on HRT. And she's like, I feel so much better. Thank you, thank you, thank you, thank you. And I said, you should thank yourself because you're doing all the work. You had to seek me out and all the resources for that. And da, 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 da. But it's an addicting feeling because there are treatments for menopause. And particularly because there's so much confusion and bias around HRT, when I started to feel so comfortable doing that, it's like a feeling that never gets old. Or for those patients who can't take HRT, if they have cancer or other risk factors, even treating with local vaginal estrogen and treating their GSM or using the non-hormonal medications for low libido. Every time patients come back to see me and they're like, I feel so much better. It's so addicting. And as an internist, because I actually started my career in OB, but then transitioned to internal medicine, now being board certified in internal medicine, I can truly say, after having spent years also doing some primary care, that there's nothing more treatable than alleviating severe menopausal symptoms. Actually, screw it, alleviating moderate to severe menopausal symptoms. It's so exciting. It's so addicting. It's so wonderful to see women thrive and feel better. And even though it's been said time and time and time again, if this were men and men's balls shriveled up and fell off at 47, do you think that they would just walk around sort of a shell of their former self? No. So why don't we treat women the same? And so that's the addicting feeling that really has made me love treating women in midlife. And then not only do we alleviate their immediate symptoms, but now they're sleeping better. So they're going to live longer because research shows, well, if you sleep 7 to 9 hours, you're going to live longer. Their insulin is better controlled. Their blood pressure comes down because a hot flash is basically your vessels squeezing and then releasing and then squeezing and then releasing. It's like, how is that good for you? Their long-term health is protected. Their bones are protected. Their sexual health is protected. And so it's an incredible feeling as a doctor.
It's interesting because in Canada and our news in the last couple of months have really highlighted sort of the whole menopause thing, and
Yes.
I think I've seen it in the U.S. as well, that we're highlighting the fact that there was lots of problems with the Women's Health Initiative. We need to rethink using HRT as the gold standard for treating and supporting the symptoms of menopause. But it's also highlighted this lack of training in the doctors.
Yes.
And it hit the news in Canada over the last month or so that the Canadian doctors actually have a gap in their knowledge because the people that are practicing right now went through school when nobody was touching HRT with a 10-foot pole.
Me
And
included.
so, yeah, right. And it's interesting because when I started practicing, I didn't have a prescribing license. That was something that I had to come into later in my career. And that was never a letter I had ever written, right? I'd never written a letter to someone's GP saying, can you please, please, please put someone on hormone replacement therapy?
Right.
And then by the time there was prescribing rights for naturopathic doctors in parts of Canada, that's where the knowledge was starting to turn, and where, we started having people seek us out for this in particular, because we had always been interested in women's health and always interested in hormonal health. And then once we met that new research that we really should be using this, right? It was like the floodgates had opened, and we have treated women from all over the place with supporting their hormones. But it definitely leaves lots of people feeling confused when the person they seek support from, the person they've turned towards, that they trusted delivering their baby and taking care of their children, now doesn't actually have the knowledge, skills, and judgment to support them at this phase of life.
Yeah, I agree with you so much that this is primarily an education problem. We talked about this on the Oprah panel. Oprah's like, why is this such an issue? I did a radio interview with, actually of all the interviews I've done, two guys interviewing me who said, well, we have treatment. Why don't we use it? And so he said, how much time do you have? So definitely, as you said, couldn't echo that enough. The WHI caused a lot of downfall in that for many years. In fact, it's now been more than 2 decades. We are still fighting the ripple after effects of that media shock that hormone therapy is dangerous and going to give you breast cancer and going to give you a heart attack, because actually none of that turned out to be true. And so medical education is certainly first and foremost the issue. And I know you actually train, have a course and train clinicians. I also just started a course to train clinicians, but there's 30 to 50 million women in the United States. And I would beg to argue probably millions of women in Canada for whom, when they go to see someone, now that they've been galvanized, they're listening to your show, they've got all of these facts, they have nowhere to go. And it is so disheartening when their doctor says, well, you can't take that. My patient, I had patients this morning, so I keep saying my patients, said actually she was in an endocrinology visit for bone health. And she said, well, what about HRT for my bones? And he said, well, that's going to give you breast cancer. And she was like, no, I don't think you know who my doctor is. But she said, I was so mad at him because I know, because I've binged all your things, Heather, and I know that the answer is there's a lot of nuances to that. It's very complex, but he's going to tell that to the next person who's not going to know. And that myth is still going 2 decades later. And so there we have case in point. Clinicians haven't been trained. They're still giving, their patients, lay women, wrong information, and the cycle continues. And so things like media outlets, national news, like this is amazing stuff.
So what are the risks? Let's talk through that for a second, because I think it's funny, when we talk about risk benefit ratios with anything in medicine, we seem to have this kind of unemotional conversation about the pros and cons of most things, right? If someone had rheumatoid arthritis, we'd say, here are the pros and cons of some significant drug classes that you can use to support your symptoms.
Right.
There's pros, there's cons, there's risks of things, and some of them are quite severe. And then there's the benefits of these things. And in most areas of medicine, we're able to have this kind of unemotional conversation around odds and risk and statistics. And yet with HRT, when we pull that onto the table and we start to talk about the real statistics, it's almost like we don't think about or listen to the actual numbers, because we're talking about things that I think matter to women, that we have an emotional connection around things like breast health and breast cancer. And so
Certainly.
even though, statistically the impact might be small and the benefit might be enormous, we still read those numbers differently. Like we would bet on this horse, like over here, that's showing so much positivity and benefit. And yet emotionally we're connected to, the consequence. So what are the risks at this point as we know it when people use, I'm going to say like body identical, don't love the term bioidentical, but we'll use it just because people know that term. If we're using the like great medications we have available right now, Heather, what are the risks?
This is a fascinating question, and the way you posed it, because I'm going to tell you about the risks of HRT, but there's one other risk, which I always talk to my patients about, which is, what is the risk of you not taking HRT? Right. So I'm going to kind of walk through those. But again, I do, when I say you're not sleeping, you're not having sex anymore with your partner because it feels like shards of glass, you're losing your bone mass. What is the risks if we don't do HRT? Now, I don't want to be an inclusive HRT person. If you are someone who can't take HRT, or chooses not to, in my new book, I actually talk about so many different options. There's a lot of different options. So I know this is a little HRT heavy at this moment, but don't think that means that all is lost. The risks of HRT, especially for using estradiol and micronized natural progesterone or prometrium, are really very low. And a new study which came out at the end of 2022 showed no increased risk of breast cancer. You're going to say, how can that be true? Well, listen, there's no increased risk of breast cancer. The biggest risk of having breast cancer is having boobs. 1 in 8 women will get breast cancer in their lifetime, and age is the biggest risk factor. And so 1 in 8, it's not a great statistic to begin with, but also we have definitely overemphasized the idea that breast cancer is absolutely deadly. Breast cancer, when caught early, not that I want anyone to ever have to hear those words, but can be more thought of as a chronic condition nowadays because of the treatment options that are available when it's caught early. But back in the WHI, if we look at even the risk then, it was 4 women out of 1,000, 4 out of 1,000 over 5 years who took oral Prempro, which is the conjugated equine estrogen, and medroxyprogesterone acetate, not the same thing as we just said, estradiol and micronized natural progesterone or prometrium. Even then, it wasn't that crazy. 4 out of 1,000 over 5 years. That risk is lower than your associated risk has never been proven cause and effect, just an association. It's lower than if you smoke, if you drink a glass of wine every day, if you have diabetes, if you have high blood pressure, if you are overweight, if any of those things are in combination. Yet, it's like when we wake up in the morning and think, oh my gosh, this diabetes is going to give me breast cancer. No, but as soon as your doctor gives you those hormones therapy, you got them in your hands, and you're about to swallow it. You're like, is this breast cancer in my hand? It's just your brain. It's the emotional part of your brain, remembering those media headlines and those media fears. When you really think that is just, kind of your body's neurologic response to the stress the media has put out there and the importance they've placed on breasts. That's what that is. So the statistics actually are that is very, very, very safe. Now, what about the risk of a blood clot? That risk is much lower than the risk of birth control pills and pregnancy. And we don't scare the bejesus out of young women, right? Women are always saying, but what about the risk of clot? And I'm like, well, have you had a baby? And they're like, oh yeah, I have 3 babies. I'm like, well, did you worry about it then? If you didn't have, the risk is so much lower than the significant amount of estrogen when you were pregnant or after your knee surgery and you were post-op and you didn't have a blood clot. So the risk of blood clot is very, very minimal. It's about 1 out of 1 to 2,000 on oral, but really almost completely mitigated to baseline risk using transdermals. So those are the risks. Now, what about colon cancer? Statistically shown to be reduced. What about bone health? Statistically shown to improve. What about cardiovascular health? Wasn't that kind of controversial? Actually, no. In the WHI, women who were within 10 years of menopause had reduction in cardiovascular disease and lived longer, 3.2 years on average, but no one's counting, and had improvements in quality of life and symptoms And there's more data to back up the fact that women who took HRT had less diabetes. That also comes from the WHI. The WHI was actually a great study. It's just that as a menopause expert, we talk about it as kind of like the turning point for HRT. Although I was in college at the time, it didn't really affect me at that moment. I was cheering on my Syracuse University basketball team and could really not caring too much about the WHI. But, 20 years later, we are still talking about the impacts. But interestingly, a lot of the safety data, a lot of the reasons I fall asleep at night very easy with my patients on HRT really comes from the WHI. And then there are some really key studies that came after that. Besides for that, it's more the annoying things about HRT, breast tenderness or bleeding, which can happen after you start. Some women have some progesterone intolerance or some progesterone sensitivity, but that's where a really good doctor can help you find the right dose and the right nuance. So those are the risks. And overall, what about the risks if you're really suffering, if your health is really declining because of these symptoms? What are the risks of you not taking HRT? They're actually really high.
I love that you brought that up, because exactly like we would present any other treatment option, or like we're supposed to, although I'm not sure in most conventional like 9-minute health appointments, how often we're going through the pros and cons of action and inaction. And yet that's like a huge part of decision making. And that we talk to patients about, well, here's the benefits of doing something, here's the risks of doing something. But if we do nothing, like what's the trajectory that we're on if we do nothing? And I think that's really important to bring up, because for that same woman who is fearful about what is going to happen when she puts this in her body is maybe that same woman who's had to increase her alcohol intake, who's decreased her socializing, decreased her exercise, increased her caloric intake.
Yes.
Right.
Yes.
And yet we're not raising super alarm bells about those things.
Couldn't agree more.
They're part of that decision making, right? Like if we don't support people in some way, the consequence of doing nothing is usually greater. I always use this phrase when patients come in and they're like, I'm eating so well, or I feel like I'm doing everything right, and yet, right, I have all these symptoms. I'm like, well, whatever we were doing right up until this moment isn't actually working. And so we need to think about a different path. And it's not common that people are able to do that risk benefit like calculation in their head, because we're talking about estrogen. And for some reason, that is a trigger word. Like that word we have given more emotion and more meaning to than anything else. I don't know how much you think social media plays into that. Like I certainly get frustrated when I look at and see, estrogen being villainized online. I think that we as in like the wellness space, certainly preys on women's fear around their own hormones. I'd love to hear what you think about that.
Oh my gosh, it makes for great marketing. Doesn't it? Because like, what do women, I always actually, there's so much to say about this. I actually haven't been asked this before. So it's a really great question. Estrogen is always villainized. One of the terms that I understand but don't love is like estrogen dominance. That's one that I hear a lot. I think that's probably more related to polycystic ovarian syndrome, which I also say it's a low progesterone syndrome. But like we act as though the hormones are the villain, when really it's the underlying physiology that's not functioning in this proper dance. And so how can we get your body to function in that proper dance? And sometimes we need to actually replenish or replace those hormones. And it's not that they themselves are the villain. It's how they're in balance. I don't even love the word balance, or how their fluctuations are causing physiologic symptoms. Birth control pills are another one. They're quite controversial at times. Again, sometimes I see a lot of, social media on, birth control pills have caused all these problems in your life. Is that true? The same can be said about how many positive things birth control pills can do, but we call them birth control pills. What if we just called it ethanol, estradiol, and norethindrone in a combined once daily tab, and just took the emotion out of it? Because it's so hard to unlock the fact that, there is this idea that like reproduction is being controlled or manipulated. And well, so therefore, how can that not affect the rest of your body? But also at the same time, we make estrogen and progesterone. These are hormones that we make. And so how can they be evil, right? But it's so easy. It would be so nice if one thing was just the villain. That's why we always want our thyroid to be wrong. That's why when my patient's thyroid's right, they're like, damn, it's just so easy. If my thyroid's off, that's why I feel like shit. But it's not always. It's not always. So if we could blame something, it just can take the stress or the pressure off of, well, maybe I really need to look at my lifestyle. I mean, when I'm eating that ice cream while I'm watching Succession, I'm not factoring it in, but I'm doing it, right? Or, whatever it is, I'm going to bed really late. I'm staying up scrolling and I'm on Zillow, which is my favorite app. And because I just love real estate. And then all of a sudden, oops, it's 12:30. Oh, okay. It's so much easier to vilify a hormone because it just makes for the perfect villain. But it's not necessarily the villain. And I think this is a great question because what's really more important is not that it's how all of the hormones in our body, there's a bunch of really important ones, balance, dance, and interact with each other. It's not that one is bad or one is dirty. I hear that too. Dirty estrogens. And I'm thinking it must come from somewhere. And patients really want to learn, but I hear all these terms, from my patients, and I'm thinking like, that sounds like we're slut shaming estrogen at this point.
Yeah, I don't know where it comes from either. And I hate the word estrogen dominance. And I feel like it's like we're trying to bring down something to explain it to women in a way that helps them understand how they feel, but then using that as this like as a pathology when your estrogen's elevated in perimenopause, it's not because you're broken. It's not a pathology. It is a consequence of that transition time. It is probably like a looped cycle where you ovulated twice in a short window of time and we've got lots of estrogen, right? Like that's the reason it's happening. But because women, I think, feel misunderstood in medicine a lot of the time,
sure,
they feel like their hormones are the big difference maker, right? They look at their partner who maybe doesn't have these month to month, week to week fluctuations. So they don't have an amazing relationship with their hormones coming into those perimenopausal years. And then as their cycles start to shift, they feel an even bigger disconnect. And then, in slides the social media marketing that says, are your hormones broken? And they go, oh, they are broken. When really, like, I think you're right around the education piece is that the more that people understand their hormones before that moment, the better they're able to separate, this is what's happening. This is why I don't feel quite like myself today, but also this is how I find a solution.
And I think that actually really points back to one of the questions you asked me actually right off the jump, which was, what gets you so excited about this? What got you to, this point in taking care of women and just focusing on this is really this as well as like, these make for great snippets on social media where you can help redirect the conversation. And it's great doing things like this podcast and making social media friends who can also say the same thing so that then they start to hear it across a couple of different, clinicians and healthcare providers. So they start to think like, oh, okay, maybe this is perimenopause. Maybe this is my erratic hormones. Maybe this is part of it. Okay, maybe I should journal and track. Maybe I should figure out my triggers. Maybe I should instead of buying the supplement that's going to wash out your dirty estrogen.
Let's talk about your book, Heather, because I think it's a good segue into like what is good information about menopause. And so walk us through that process and what question is it answering for people?
Yeah. So thank you so much for asking. My baby is called Unlock Your Menopause Type and hit shelves June 6th. The inspiration for this book was seeing patients for the last decade. And what I started to notice was some patterns and also actually out of individually treating so many women, then the patterns, because I love the individualized approach when I see my patients. And even if it's teeny tiny nuances, like, take your progesterone just 12 days of the month. I get these questions all the time on social media. How do you decide? And do my best to educate, but it really comes down to when it's just me and the patient looking at how their body functions on these medications. But I started to see these patterns that could help people individualize their treatment a little bit more. And my aha moment kind of came for like when I kind of could figure out someone's type and explain that to them, they kind of had this aha moment. Then they were more likely to choose a treatment regimen that more targeted their symptoms and, crucially, feel confident and stay on it. And so a lot of times, I see patients that come to me all the time, actually, who doctors have even prescribed HRT, or they've taken it for a little bit, but then were confused or didn't feel right and then just stopped. And so one of the big confusions around HRT, and one of the things I hope my book really does is to be my voice where I can't see everybody, so that they can feel a lot more confident about their regimen and why they're doing a certain regimen. And so that's kind of what my book is about, Unlock Your Menopause Type. And I'm very proud of the fact that I hope it to be one of the first really inclusive books, because not all menopause is natural menopause at 51. The first type is premature menopause for young women, women with premature ovarian insufficiency or Turner syndrome or surgery really early. Sudden menopause is the next type for women who have usually thrown into it suddenly without any warning from chemotherapy, from cancer, or Lupron for endometriosis. And so what about those women who have gynecologic cancers? What does menopause mean for them? Full throttle menopause is symptoms from head to toe, and how efficacious and easy actually a low dose of HRT can be to really help the full throttle and really answer that question that we spent a good amount of time talking about of, for those full throttle patients, what's the risk of not taking HRT? The mind and mood type of menopause, where I find a subset of patients have their biggest life altercation in depression, anxiety, brain fog, and cognitive changes, and what that means, and why it's important to actually think of that as a part of menopause and not a completely separate diagnosis of bipolar or major depressive disorder. The next two, there's the seemingly never-ending type of menopause for those women who think or wish that their symptoms are just going to go away, and then they look at the what does that mean? And then the silent menopause type, even if you never had a hot flash for a day. The big part about menopause is that your body still changes, and it changes forever because we're not going to make estrogen again. So what about your brain and your bones? So that's what I'm really excited for my book. And I hope it makes a great book club. I hope it makes a great gift to give to a friend, and just really kind of has people start talking about like, what's your menopause type?
Yeah, I love that sense of belonging, especially for those people that feel like they don't fit, right? And that's certainly like an unintended consequence of the conversation about menopause being brought to light, right? That there's big conversation about HRT. There's big conversation about women at 50 who are at the pinnacle of their lives with aging children, aging careers, aging parents, right? And having to literally carry the weight of the world on their shoulders while they don't sleep, right? And that is becoming the front and center conversation in menopause. And that can very easily make other people and women feel left out of the conversation if that's not the path they took. And so I love that it has that inclusive piece to it to say, well, what is different for you if you have had surgery? What is different for you if you went through a million rounds of fertility treatment and it turns out it's because you were, having premature ovarian insufficiency at 41? Like, what does that look like for you? And I think, those people may not necessarily need different solutions, although I'm curious what you think about that. But it's more the acknowledgement that they need to just be acknowledged differently, I think is incredibly important.
I couldn't agree more. And in each type, I go through what I call kind of baseline treatment plans if you use HRT, if you don't use HRT. But then I also have a section on what I think could be really helpful in terms of your headspace And a lot of times it's finding support groups, and some support groups for women who are feeling similar to you, or age-wise similar to you, or medical history similar to you. Because I certainly agree, the acceptance, that validation that your menopause is a little bit different than, when you just Googled the term menopause, is really, really crucial. And some little tips on, here's some different exercises if this is your type. Here's some different foods to kind of help with your symptoms if this is your type. So kind of really holistically looking at women and helping them to see the bigger picture of what this means biopsychosocially.
And what do you feel like is the biggest mindset, shift that people need to make at that time of life? Because I do think there's that sometimes when I'm the one to diagnose patients with either premature ovarian insufficiency or to call out that I think they're in perimenopause and they didn't see it coming, right? Because maybe their knowledge was different than mine. Maybe they, their vision of menopause was that like a light switch happens at like age 50. And here they are sitting in my office crying at 43. That it does bring up a lot of grief for women. Yeah. It's like, it's funny because they're like, I wish I never got my period again. And then they skip a period and they're like, oh, am I going to menopause?
Give me the pads back.
Women with like that side or like that grief piece around that change of life.
I'm not, because I'm pretty open and honest. I'm 40, 41, and I definitely experiencing some perimenopause mood fluctuations. Oh my gosh. It took me like a few months to realize this. Me, took me a few months to realize, even me, guys. I haven't gone through menopause myself, but I have done so by proxy, hundreds of times. And there's so many different emotions people have. And certainly I think I see the more prominent anger of like, why didn't anyone tell me this? Or why have I been mistreated for so long? I feel that if I'm the one diagnosing them, actually, often I'm not the one diagnosing them. Interestingly, they kind of know before they see me, which could be just because they've binged my content or someone told them, but they didn't love their treatment plan. So they're coming for a second opinion. And there is this grief of what it means to be youthful, what it means to be fertile, what aging means, how we're going to redefine this, or if you even freaking want to at that minute in time, And so I think the emotions there's a wide range, and I don't know how I will feel. I probably will feel all of those same things exactly, even though I know more. But that doesn't mean that even I am not going to have those same emotions of feeling like at a loss, or feeling that my body is really changing, or really feeling as though, aging, whatever that means. But I really like to encourage my patients to first just focus on feeling better and focus on feeling them. And a lot of times I ask my patients, I say, in a few months, if you could see the best version of yourself, what are you doing? And they're like, oh, I'm getting up in the morning and I'm running, or I'm getting up and I'm working on my book that I haven't worked on for 2 years. And I'm cooking with my family again. And I'm taking my afternoon walks. I'm having sex with my partner. And I can see the spark back in them as they think about their best version of themselves. And again, back to what we talked about a while ago, why I love this field of medicine is I get to see that. And then they really can feel though they can flourish, that they can thrive, and they can redefine what this transition really means, throw away what the hell society has told them, and really redefine it for themselves. I know that sounds like a little cheeseball-y, but that's all totally coming from the heart.
No, I don't think it sounds cheeseball-y at all. And I think it's like aspirational, right? Because I think even when women are thinking about those things, it's almost like when you try and 5-year plan and you have PMS, right? I'm like, this is not the week, right? Like, just put that down. Like, let's feel a little bit better, right? Think about like this moment, and we can talk about what your 5-year plan is after your period's over. That there's a little bit of that, right? Like that quite often when we're seeing people in those moments, I mean, no one's coming into the office because they feel incredible.
Right.
That's not usually, even though women are way more preventative about their health than men can be, not to stereotype, but it's common. They still usually aren't coming into the office when they feel 100%, right? And so I think some of that like grief and loss is also around the worry that they'll never feel the way they imagined,
Mm-hmm.
right? Or that vision of themselves that you just painted there doesn't feel accessible, right? Because they're
Right.
like, yeah, I would love to pick up a paintbrush, but I feel too bitchy, or I didn't sleep well enough, or, I can't actually move past the way I'm feeling to get there. So I think that's a lot of it, actually. And so I love that advice of like, can we just focus on feeling better right now and then start to envision what we really want this to look like? Because it's probably just not accessible on that day that we're actually meeting them.
Right, exactly. Kind of like small wins. What are the small
Small
wins?
wins. That's
The
right.
small wins.
So
Yeah.
I'd love to hear what you think about like the future of this, Heather. And I know I asked you a question before we hit record. I'm like, what's the not the yucky part of this conversation, but what's that part of the menopause HRT treatment research conversation that is just below the surface that, people really only starting to come to understand when they deeply are an expert in the topic. And you mentioned the concept of prevention, right, in menopause, and either A, whether we think HRT is going to prevent things or whether the research is going to move in that direction, or how we frame what we do know about prevention right now for our health seekers that are looking for longevity and looking for solutions when the research is like, right? It's like, it's there, but it's like, it's not perfect. So I'd love if we could talk about that a little bit, because I do think sometimes when we swing the pendulum on the HRT conversation in the complete other direction, and you'll see online people talking about HRT like helping you live forever. I think we probably are going to settle somewhere in the middle, but I'd love if you could walk us through that a little bit.
I'm happy to. This is a dicey one because the answer on the test is no, HRT is not for primary prevention. And in the United States, we have something called the United States Preventative Task Force Service. There's probably something similar in Canada, but almost every year or 2 years, they reevaluate HRT and they always give it like a failing grade, like a grade F, like should not be used for primary prevention. And people always message me like, did you see this? And I'm like, of course. And they're like, what? We should do a podcast on this. I'm like, it's never going to change because estrogen is emotional. And they're never going to say, yes, estrogen should be primary prevention. I don't see a day where that's actually going to happen. What I could see is maybe a lot more clinicians are willing to at least acknowledge the fact that if they have FDA indications for HRT, that it could also help with cardiovascular disease, reducing diabetes, helping you live longer, which the WHI said 3.2 years, so not forever. But I will take hormone replacement therapy for prevention. Absolutely. How could I not? I see this every single day, and I study the data and I study the research every single day. Now, there's also probably colleagues of mine that would jump out of their skin hearing me say that because it's not exactly what the textbook says or exactly what the guidelines say, but guidelines and textbooks are written by humans and we're all biased in some way, shape, or form. Whether we're biased because we want our research to be the best, or we want to go down as being the doctor who wrote the WHI or just like if you watch Succession, there's always self-interest involved. Okay. No matter what, even in science, of course, we wish there wasn't. We wish this was pure, but it's not. And when it comes to women's hormonal health and women's midlife health, which for decades has been left completely neglected, you better damn be sure that there are some biases here. And there are folks whose self-interest or their old books or their old papers or their whatever are very important to them, that message sticks around. Again, because of the way that politics are ingrained in science, estrogen HRT is never going to be indicated for the primary prevention of cardiovascular disease. I don't think I'll live to see the day. And that's not necessarily what I want. I don't really care. I just want more people to know that. And I want more clinicians to at least be able to acknowledge that it could be helpful for that and stop saying it's going to give you breast cancer and it's going to give you heart disease and heart attacks, because those things are really not true. When you're looking at using estrogen for women with no known contraindications who are less than 10 years from their menstrual period. And I bet the majority of women are asking about menopause, not 15 years later. It's just that they've been ignored every time they bring it up for so many years, or they felt like they haven't had a space to bring it up. So what I hope is that eventually someday there's an HRT shortage. In the United States, about 7 to 10% of women are on HRT. That's up from like 4% at like a peak of 47% before the WHI. I would love it if 20% of women were on HRT, 25, 30, 35, shoot for the moon, right? 40%, because so many women, the majority of women are excellent candidates for HRT. Again, while I kind of wrap up my thoughts here, it does not mean that I think it's the one and only option. It doesn't mean that you're doomed without it, but just to really put that message out into the world again, that if men lost their testosterone, they would take testosterone. We lose our estrogen and we live 5 more decades without it. And it's a hormone that's helped us live wonderful, flourishing lives for 50 or so years. And so there's so many reasons, so many women are good candidates for it. That's kind of just the message I want to strongly put out there so that, maybe 12% of women will take HRT.
Well, I can't agree with you on the HRT shortage because we have had HRT shortages.
No, I know. Actually, it's probably don't
wish for that. Knock on wood.
Don't wish for that. Oh no, I actually know what. Yeah, it would be like that would be I actually, you know what? We're going to stop talking about that right now. We're going to shut that conversation down right now.
What we would love is more manufacturing plants for HRT. That's what we would love. Yes. I love the way that you put that, Heather. And I think, it's what I always try and do with this conversation is like, if we inserted any other scenario, gender, medical condition, pharmaceutical, or even if we replaced the conversation with a supplement, what would our level of tolerance be around this risk? And I think the prevention question is so interesting because we're willing to take lots of things that are not even on the same stratosphere of conversation around prevention to maybe prevent things. And yet the biological plausibility and some of the studies we do have about HRT are so positive, and yet we will not go down that rabbit hole, but we're very willing to take like fish oil and some other things that, the data is like equal or worse from a prevention perspective than it is for HRT. I have the ApoE4 gene. And so I think often about the impacts of HRT on cognition. And I know the data is like not good enough to recommend it at a public health level, but I will use it, right? Because, when we look at some of the biological plausibility data, I'm the group that benefits the most. And even though the research isn't there, if I'm going to take CoQ10, I might as well also take HRT. And yet we're so much more willing to make that decision about some other substance, right? If someone said, well, taking Lipitor might also decrease your risk of cognitive decline, Jordan, I'd be like, all right, give me some, right? And yet, then again, this emotional part of the conversation feels so uncomfortable for most people and their clinicians. I just find it so fascinating. What's your lasting message for our listeners, Heather, and how can they find your book?
Oh, my lasting message is just keep being proactive about your health. And that's really it. Your health is your wealth. Your health is your future. You can find my book, Unlock Your Menopause Type, anywhere books are sold. And thank you so much for having me on and having such a fun, easy, candid conversation. It was so great to talk.
Thanks so much, Heather. Yeah, and we'll put the links to Heather's website and links to grab her book in the show notes as well. So you can just click back to your podcast player and easily grab yourself a copy. The book went out on June 6th, and so you are fully able to grab it. Thanks so much, Heather, for spending time with me today.
Thank you.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.